Thank you so much, Carol, and I can't tell you how happy I am to be here with all of you, talking about nursing and midwifery and improvement. Those are my three favorite topics, and so I'm delighted to share some time with you this morning. I thought I'd make you laugh by sharing my picture from 46 years ago when I graduated from nursing school and began to think about what a difference nursing could make. Early in my career, I thought my job was to take care of patients, one patient at a time. And to improve the work that I was doing, I kept working on using improvement skills in a very rudimentary way to try and take care of patients, one person at a time. But I then realized that if we were going to make a difference in our patients' lives and in the health of the population, that we needed to think across the system. And that's what you'll learn today. You'll be thinking not only about how to improve the care of a pregnant woman or a new baby or a person in an ICU, but how also do we look across the system? And you'll hear some wonderful improvement stories. So building those improvement skills is really going to help us to deal with the challenges that we all face. Changing patient and family expectations. I love the work that you're doing here in Northern Ireland on co-production. It's going to make all the difference in the world, and I'll give you some examples of that. Looking at research, it's coming at us at a breathtaking pace. And so how do we make sense of that and incorporate that into our daily lives? Technology and new equipment. We were just talking at our table up here about how patients are assembling new ways to use technology, and in some ways they're ahead of us by looking and exploring at technology. And expanding the mission, you might know that at the Institute for Healthcare Improvement, where I've been for the past 25 years, we began our journey by thinking about improving patient care in a hospital. And then we said, we need to improve care across the system. And then we said, we need to really incorporate not only care for someone who's sick, but we also, especially as nurses, have to understand what's our role in keeping people healthy. How do we move upstream and prevent illness as well as take care of people when they're sick? And how do we think about waste in our system? So these challenges are going to require us to think in a different way, to think about how do we empower people so that the ideas that they come up with, and especially when they're frustrated, can really spawn new ideas and new models of care. And how do we see patients across the system, not only when they're hospitalized, but what's it like when we discharge them? Although I want to eliminate that word from the English language because there really are no good definitions for that word, I think, discharge. And the idea that we would discharge someone, to home, doesn't feel right at all, and you'll see some examples of that. And co-design and co-production. So the Triple Aim is an important kind of foundational effort for us. Back in 2007, Dawn Berwick and a number of our other faculty and I were looking at what does health and healthcare really look like. And we drew this diagram, and we started going around and talking to doctors and nurses, healthcare leaders around the world, and we said, where do you see yourself? Some people said, my job is making care better. Some people said, my job is making health better. And some people said, and I work on finance. But we couldn't find anybody who was working on all three. So we put that little black dot in the middle and said, as healthcare providers, as healthcare leaders, we all need to work in the middle of the Triple Aim. We need to understand how all these elements come together. And so I see nursing at the center of a transformation. I see us as the key leaders because we're the ones who look across the system. We're the ones who not only know the patient's symptoms, but the patient's family. We're the ones that know the assets as well as the needs of a patient and family. And so I see us as the people who can step in and lead the transformation that we need to a new way of thinking about care. So I wanted to share with you a couple of nurse-led innovations where one nurse working in his or her setting was actually struggling because the construct of their work was challenging them. All of these nurses were frustrated in one way or another, but they had improvement skills. And so they started by saying, what if I tested a new model of care? And in doing that, one patient and then 5 patients and then spreading it, each one of these nurses has now had a global impact on making change. It came from frustration plus improvement skills is equaling the transformation that I'm talking about. Home care. Some of you might know Joost de Blok. Joost was a home care nurse in the Netherlands, and he was providing home care and loved it. Every day he'd go out, he knew the patient's families, he knew the patient's needs. I actually went to the Netherlands and went on home visits with Joost, and I learned what it's like, because I had never done home care, to really be in someone's home and see the environment, to see the family's culture, and to see the social needs as well as the medical needs. So Joost loved his job. And then the government in Scotland, in the Netherlands, decided to change the way home nursing was delivered. They said to Joost, no more can one nurse go out and take care of all of the needs. We want you to work to the top of your license, you know? So you can go out and do colostomy dressing changes, but we're gonna send in an LPN to do the bath, and we're gonna send in a nursing assistant to do the feeding. And what happened was all the joy of home nursing was gone. Joost was not going in to take care of a person, but running in to do a task. And the people, the patients, hated it, because it wasn't like Joost is coming today. It was like, this morning I have this, and then this afternoon I have this. And their whole life was consumed by fragmented care. So what he decided to do was quit his job. He was so frustrated. And he had learned quality improvement methods from IHI. And he said, I can see a different way. So he created a new model that he calls Berzorg, which means neighborhood care. And I know that some of you are working on doing something similar, introducing this notion of neighborhood care. It has transformed the way healthcare is provided in the Netherlands. He created, first of all, a very small team. He put together a tiny team in the beginning. And these nurses, 8 of them, 12 of them, would get together for breakfast. And I went and sat with them at their breakfast meeting. They were in a little hall in a school, or another time they were in a municipal office. They would just take an office and go meet, and they would talk about all of the families. They would talk about their own families, and they would talk about all the families in their neighborhood. What happened was they created an organizational model where this small team of nurses effectively was providing better care, because one, they knew their patients and families deeply, but they knew each other. And so the day I was sitting with Joost, one of the nurses said that her son was having trouble at school. And, oh, thank you. See, the nurse sends the water up. Thanks so much. This wouldn't happen at every conference. But so what happened was, at the breakfast meeting, one of the nurses said that her son was having trouble in school, and she thought that he might be suspended. And she felt like she should go and visit with his teacher that day. All the other nurses said, well, we can figure this out. And they rearranged the schedule so that that nurse was covered for the afternoon to go with her son. That's the kind of community that a small group of people sharing a mission can work on. So it started very small. When I went to visit him, there were 8,000 nurses already, providing 60% of the home care across the Netherlands. And what happened was that they weren't just managing, they were building on trust. So better outcomes, lower cost, better health, because they were working not just on the colostomy dressing, but they were working on relationships in the family. So here, this one nurse, feeling frustrated, decided to use some quality improvement methods, and from one team, spread to teams all over the country. and really has created a sense of what a nurse can do to create the triple aim: better health, better care at a lower cost, and much more joy in work. Berzog is now spreading around the world, and I visited with Jos in different countries as he's beginning to spread the model. Here's me in the Netherlands. Of course, now, home nursing in the Netherlands is done by bicycle. I'm 5'2". Everybody in the Netherlands is like 7'2". So I had this massive bike that I was trying to ride over the bricks in the red light district in Amsterdam, crashed my bike into a planter and broke my tailbone. So I had to walk on my home visits, but Jos walked along with me. And what I saw there was incredible joy that came from frustration plus quality improvement, and how that's changing people around the world. So I think the magic is seeing the problems in the system and then working in a different way. You may also, if you've ever heard me talk, have met Christian Fahman. I was in Sweden, and I was at an academic medical center, and I was taking my tour and walking around, and I came to this unit that looked really different. And I said, "What is this place?" And they said, "This is the patient dialysis wing." Now, I know patients do their own hemodialysis, their own peritoneal dialysis, but I had never seen a wing of a hospital where the patients let themselves in with their own electronic card key. They make coffee for the nurse because they're there well before any staff. They do all their own testing, they prep their equipment, they cannulate themselves, they make their own schedules, they clean up after themselves. This is a wing of a hospital, an academic medical center, where all the patients take care of themselves. So I said, this is co-production, I love this. I said, "How did you start this?" And they said, "Well, we're very visionary, we've been working with IHI." I said, "I have never seen a CEO say to a head nurse, 'Oh yeah, sure, build a wing, and all the patients can take care of themselves.' How did it really start?" So I met Christian Fahman. He's a young guy who was a mechanic at Saab Avionics. He built airplanes, and he came down with glomerulonephritis and ended up on dialysis. Once he started, he said after a few weeks, he said to his nurse, "I'm a mechanic, I can do this, train me." So she trained him how to do it, which is, again, not uncommon. But then the 73-year-old lady in the next bed said, "I want to learn how to do that. What are you doing?" And so they taught her. And then pretty soon, 75% of all the patients in that hospital are doing their own dialysis. But they were still intermingled in the room with the patients who were very sick and would always need a nurse to do their dialysis. So the head nurse and Christian started talking about the fact that if they could separate the two populations and put the well people in one place and the sick people in another, that they may be able to produce not only better clinical outcomes, but decrease cost. So the head nurse went to the CEO, and she was multilingual. She said, "Here's Christian. Christian's doing his own dialysis." Then she extrapolated to all the other patients in her unit who could do their own dialysis. And then she talked about the human cost, that it was better when they came to in-center dialysis because they had social connections with other people, and then here's the financial savings. So she created this story that went from frustration of Christian to potential for greater improvement than anybody could ever see. So I asked Christian, "Why did you ask to do your own clinical care?" And he said that he, like many young people, had done some research on glomerulonephritis and on kidney failure. And he said, "I want to live a whole life." He said, "It matters so much to me that I'm not defined by my illness." At the end, I said to him, "But what about safety?" And I thought he was going to say, "Well, I have a phone, I can call a nurse if I need her." And he said, "Well, of course the care is safer in my hands." He said, "First of all, I always do it the same way. You always do it differently. And second," he said, "it's my bacteria, not yours. And none of these patients ever get an infection because it's their bacteria." I asked the head nurse, Annette, "Tell me, what do you think your job is now if you're not taking care of patients?" And she said, when a patient gets admitted to her dialysis unit, she said, she looked out one day and said, "How many of these patients are well now, but they're not working. And just like Christian, they said they wanted to work. So when a patient gets admitted to her dialysis unit, the first thing she does is she sits down and she helps them update their CV. That gives them hope that they will get back to a different life. And I said to her, "What's your job?" And she said, "My job is measured by how many people are working." I've not found other places that people, where nurse leaders would say, "My job is to get people back to work." But I loved that. So she convinced the CEO to build a new building, and he said, okay, go ahead. She was going to build something that looked very medical. When the patients came in, they said, "This is what we want it to look like." They said, "This is about getting well." So they said, "Don't invest in comfortable chairs and warm lighting, invest in exercise equipment." And every patient who comes in, either comes in 1 hour before their procedure, or they, like the man on the lower, your lower right, they dialyze while they're exercising. And the health of this population is breathtaking. I've been in dialysis units from Vancouver to New Zealand, and I've not found units where people are as healthy as I see in this unit. And it's because of co-production. It's because we're not taking care of them because they're sick. We're empowering them, one patient at a time, to now look at the cost of their care calculated at 50% of what it used to be when we were taking care of them. And they have lives. So I had said to Christian, when I first met him, "What matters to you?" And he said, I want to go back to work. And when I was with him a few years later, I said, "Christian, did you go back to Saab?" And he said, "No." And I was thinking failure. And he said, "No, I'm an RN." He said, "I'm the head nurse of the ENT unit." Because I went back to school. I was here in the hospital a lot, and I got to really appreciate what nurses bring. And so now I'm a head nurse. So I said to him that day, "What do you want now?" And he said, "I want to get married." He said, "I never had faith that I could live a life like this, but I want to get married," and I did get invited to his wedding. And the next time I was there, I said, "What next?" And he said, "I want to have a baby." And this is Wilmer, his little baby. Now this guy, he says, "I would have been a patient for life. I would have not been able to work." He said, "I am a full person and I'm living life to the fullest because that nurse and I had a conversation, and then because we use quality improvement to spread it to the 73-year-old. And as you start to use quality improvement with the frustration you feel, you can change." And so I actually then got the nurse, Britt Marie, his nurse, and Christian to fly to Waco, Texas. There was a nephrologist in Texas who said, "Oh yeah, the Swedes, they're a whole different group. That might work there, but it will never work in Texas." So Christian and Britt Marie, the nurse, flew to Texas, and they taught the nephrologist how to take care of patients. The nephrologist, Richard Gibney, is now spreading this all over Texas, and it is amazing to see the results that he's getting. He called me the other day. He's now spreading it across the United States. He told me the other day that he has 3 patients who are completely blind who do their own hemodialysis. In one patient who's paralyzed from a stroke, and the patient invented a little sling that he throws around his paralyzed arm and he pulls it over so he can cannulate himself. He said, "I never had trust in my patients until I used quality improvement methods." In Philadelphia, again, a physician named Ed Jones says, "My population is very different. They're African American and they have a lot of other chronic diseases. All the results are the same, and everybody in the United States has started to measuring how many people work who are in this as the outcome." And so then the patients got together and they said, "You know what? When I was diagnosed with kidney disease, some doctor told me, okay, show up at the hemodialysis clinic." And they said that might not be the right thing. So they invented an app, and you can go on your iPhone and download My Dialysis, My Choice. Patients invented it. So when a doctor says to you, "You have kidney failure and you're going to need to go on dialysis," now the patients say, "Open up your app," and it asks you questions that the doctors never did. It says, "Do you live alone, or do you have somebody who could support you? Is someone there to take deliveries if you wanted to have home dialysis? Would you rather have the company of friends? Do you have a dog? Do you want to sleep at night or dialyze at night? Are you afraid of needles? How good are you with pain? And you fill out the app, and then it tells you what kind of dialysis, hemoperitoneal, inpatient, or at home, or in-center might be best for you. So again, it's an example of a frustration plus quality improvement really driving change. And Christian and his nurse are now spreading this model around the world. It's so encouraging for me to see people who said, no, that will never work here, now calling, come help me. To see the patients that I met originally in Sweden when they were being dialyzed, then went to doing their own dialysis. And now when you walk into a dialysis unit in Sweden, one of these dialysis units, more of the staff are patients than clinicians, because they're the ones teaching young men, teaching other young men, this is how you do dialysis. And what they're finding is that the uptake and the reliability is much better when they actually have a patient teaching you how to do your own clinical procedure. Another example, a nurse frustrated at Johns Hopkins in Baltimore, in Maryland, in the United States. This is an advanced nurse practitioner, and her name is Sarah Zanton. And she used to take care of elderly people at home. And Sarah, when I met her, told me that she used to go out to people's homes with her little bag, and she would draw blood and take vital signs and check prescriptions and do all the clinical stuff. And then she said, I'd look up and I'd say, whoa, how can this person live here? The frailty of the environment was actually causing more illness than the person's clinical condition. So Sarah did PDSAs. She got one small team. She asked an occupational therapist and herself, a nurse practitioner, and a handyman to join her, and the three of them became a team. And the three of them started going out to visit people's homes. This cross-functional team was incredible. One, because when they got in the car to come back to the hospital, they would say, what did you see? What did you see? And they all saw different things. And they realized how sometimes our professions limit our vision. But when you get together a team of people who have very different skills, how empowering that can be. They also found that the handyman had a greater impact on people's health than the nurse or the occupational therapist. That the handyman was able to see potential risks today. They did common things like install guardrails, pick up scatter rugs, and actually produce much better clinical outcomes. So Sarah was able to take a story of an individual patient, and then she began to, do PDSAs and extrapolate to the population at large. So she started growing her project from a test to a project that she now calls Capable, keeping the patients at home. And then she could speak in finance. And she said for a roughly $3,000 investment, she was saving $10,000 in hospitalizations and emergency room visits. So it's that notion of a patient extrapolated to the human cost and the financial cost, and the results are unbelievable. It's not just the financial savings, although that resonates with some of our audience, but it's keeping people safe. It's families that now feel like they've got greater trust in the system. It's got joy in work because the team is working together rather than one person like Joseph Block racing around by himself. A team of people is working and they're seeing things in a different way. And the complications are driving down healthcare costs as people are staying safely in the community. The other thing that I really loved about this project is that it created joy in work. The sense of team was wonderful. At the time when Sarah started this, there was some unemployment problems among people like handymen. And now the handymen are such an integral part of the health team. The handymen now have a school where they're training other guys and women to become handymen. And it's become sort of a way of looking at healthcare much beyond the clinical symptom in front of you. That came from Sarah's frustration that even though she was there in someone's home and taking as good a care of them as she could, she wasn't able to take care of it all by herself. So again, frustration plus quality improvement, producing better outcomes. And in Boston, Massachusetts, I came to become friends with a midwife named Sharon Rising. And Sharon told me that she was a midwife, and she works at Boston Medical Center, which is the hospital in Boston that takes care of most of the people who they're on the lower end of the poverty, they're in poverty already. And so Sarah was telling me that she would, Sharon was telling me that she would come to work each day, and she would walk in to see a patient, and she said that when she was walking out, the patient would often say, one more thing, one more thing. And then she'd walk into her second appointment and say, I'm sorry I'm late. And then the third appointment, I'm sorry I'm late. And then she'd never get home for dinner, and she felt such frustration that she raced all day but could never keep up with the demand. So one day she said to herself, you know, I'm doing the same thing in every room. Why don't I do it once rather than 20 times in a day? And so she said, did a test. She got a group of 10 women who were about the same phase of pregnancy. And she said, do you want to come to get your care together rather than separately? And she created the centering model. And I know some of you are implementing centering pregnancy, but I would encourage you to think about centering as a model of co-production, that it will change, I think, a lot of the way that we think. So the patients don't come and sit in an admitting area and sit in a waiting room and then get called in and take off their clothes and get done to. The patients come to a little conference room. The one I was in was about half the size of this room, and the patients come in and they take their own vital signs, they do their own urine specimens, they take their own, they weigh themselves, they're tracking on control charts all of their vital signs. So the power is in their data, which they then share with the clinicians. When they come into the room, again, they don't get undressed. They sit like these women around a little room, and they start talking to one another. And these women often have home problems that would paralyze them if they didn't have a social support. So the conversations are amazing. When I went and sat in on the centering model, I asked to follow a patient. I met Nora. She was 24 weeks pregnant with her first child, and her husband was still back in Nigeria, and she was very worried about having this baby alone. And so she took all her own vital signs and did all that. She was very capable of taking care of herself, but she was really scared about taking care of her baby. And so I said to her, we were sitting around the room. There was a midwife, an OBGYN, and then in my room there were 14 women about the same phase of pregnancy. And so I said, Nora, tell me, what are you afraid of? And she said, I am so afraid of pain. She said, I'm terrible with pain. And she said, I really don't think I'm going to be able to have this baby. And so I was interested in how the midwife would respond. Me, I would have sort of jumped in and started telling Nora, no, this will be okay. And the midwife sat back and she said, 2 of you in the room have had babies before. Why don't you tell Nora what it's like? So the first woman said, it is the worst thing you will ever go through, ever. She said, the pain is excruciating. It's like someone is ripping you apart with a knife. And she went on and on and on. And she said, this is what you do, Nora. She said, run into the emergency room and scream, epidural, epidural. And then she said, then you'll be okay and you can have the baby. And so the midwife calmly turned to the other patient who had had a baby, and she said, what do you think? And she said, yeah, it is the worst thing you will ever go through in your whole life. You'll get a baby at the end of it, but it's really, really bad. And the 2 of them talked about the pain. And then the second woman said, but I didn't want an epidural. So she said, the midwife gave me some clues as to how to do this. Now, those of you who are midwives have probably done this 100 times, but I had not. So the midwife said, okay. She said, put out your hand. And she poured a cup of ice into each one of our hands. And then she said, just let the ice melt. And if you've done this, after about 10 seconds, everybody was like, and pouring the ice cubes back into the cup. So then the midwife did something, again, that was new to me. She said, okay, I'm going to tell you to do something. Relax your hair. Now, I was a doula for years, and I never heard this, but she said, relax your hair. And so everybody said, how do you do that? She said, you'll figure it out, just relax your hair. So you can imagine right now, relax your hair. And so she said, she started talking a little bit more softly, and she said, relax your hair. And then she said, relax your jaw. It's all right here, all your stress. She said, you can close your eyes if you want to. And after a few minutes, everybody was relaxing their hair and relaxing their jaw. And then she said, breathe this way, just a few minutes. And then she said, okay, stick out your hands. And she poured ice cubes into our hands, and every single person, the ice completely melted. And Nora said, I can have my baby. And it changed my whole perspective on how do we work with patients. And this group, watching them, was incredible, because it wasn't just, I'm worried about pain. It was, I have intermittent partner violence when I go home. I have 3 other little kids, and I don't know if I'm gonna have the strength to take care of them. And they shared their experiences, clinical and home, and it totally changed the perspective. These women, they are, and now some of the men are coming together, and they won't come apart. When they went to the pediatrician with their baby, they're like, I'm not bringing my one baby to a pediatrician. We want centering pediatrics, and we want centering, and it started to spread because it taught me that the social determinants matter just as much as the clinical condition. And if we put someone in the exam room, take off their clothes, do something to them, and then send them home, then we're not dealing with the triple aim. So this nurse, Sharon Rising, with her frustration and using PDSA, created the centering model, and look at the results. We're now seeing dramatic decreases in preterm births, especially for the underserved population in Boston. We're seeing improvements in breastfeeding. And I was asking someone yesterday what your breastfeeding rate is here in Northern Ireland, and I was hearing it's somewhere, after 6 weeks, you're pretty high, like 50% or 60%, but after that, it kind of drops off. And what I'm seeing now is in the centering model, and I had the great opportunity to go visit in Cuba, the Cuban health system. And there, they have 83% of women are breastfeeding after 6 months. And when you get off the airplane and everywhere around Cuba, there's pictures of bottles with a big X over it. And there's pictures of pacifiers with a big X. And the kids are taught in 1st grade that breastfeeding is the first vaccination. So they've created this sense, again, through frustration and looking across the system, that we can produce much better outcomes if we think in a new model of care. And a different model is a nurse that I personally had a chance to meet with. A few years ago, I read a journal article, and I have to say that most of the time journal articles don't move me to change the way I think. I mean, they're informative, but they haven't tended to transform the way I think and work. But this one was. A few years ago, I read an article by Susan Edgman-Levitan, a nurse practitioner at Mass General, and Michael Barry, a physician. And it was just an article on shared decision-making. And in the middle of it, it said, we can't only ask the patient what's the matter. We also have to ask what matters to you. I went back, I was actually on my way to Paris to give a plenary talk, and there were 4,000 people in the audience. And I said, when you go back to work, don't just ask the patient what's the matter. Also ask them what matters to you. And this nurse, Jen Rogers, was from a pediatric hospital in Glasgow. And she went back and asked her patient, what matters to you? The very first patient that she saw was a young girl named Kendra, who's severely autistic. She's never spoken a word in her life. And so because she couldn't speak, Jen gave her a piece of construction paper and an art kit. Do you know what I'm saying? I know my Boston accent gets in the way. A-R-T? Okay. So she gave her some crayons and things and said, make a poster, put your first name and your age, and say what matters to you. And Kendra's father, who's her only caregiver, helped her to write this. And she said things like, I don't like medicine by my mouth. I will fight you. It's a 3-person job. And she said, I say hi by pulling your hair. And she said, I'm very fast on my feet. I will make a run for it, ha ha ha. And she said, I like noisy toys and I like things to help me cuddle. Well, the night that she made this, her father, her only caregiver in her life, had a cardiac event, and he was taken by ambulance to the adult hospital in Glasgow, and Kendra was all by herself. And the nurses said, because that poster was on the door, we knew how to take care of her. We didn't, if we walked in and she pulled our hair and she started fighting, we may have restrained her or medicated her, sedated her, but we knew who she was. And so this spread all over Scotland now. Every patient room in the country has "What matters to you" poster. It's not a whiteboard that says, my nurse today is, and then it's empty, which is what I see most places. It says, what matters to you? And people bring in their pictures of their dogs and what they hope to get by the end of this hospitalization. So it's spreading all over the world. I was in San Francisco with a nurse practitioner and a doctor, and they were trying to help the residents and the nursing students think about how to do this. And the students were saying, we're too busy. We can't go asking them what matters to them. You know, we're trying to take care of them. We're in there doing vital signs. And so what they did was a test. They said, okay, bring us to the dullest patient on the unit. And they said, oh, we know who that is. She's an elderly woman, she's homeless, she's been in the hospital for months, and we can't send her home because she has no home. So the physician and the nurse leader walked up to the patient, and they had all the students around her. And they said, how long have you been in San Francisco? They said she only speaks in one-word answers, but she didn't. She said a long time, years and years. They said, where did you come from? Ireland. When did you come? 1912. Have you ever been in the hospital before? Once for a broken arm. How did that happen? A trunk hit it. A trunk, what kind of trunk? A steamer trunk. How did that happen? The boat lurched. The boat, why? It hit the iceberg. So this woman had come over on the Titanic and had lived the most incredible life, had bad times at the end of her life. But when they found out that she came over on the Titanic, everything changed. She wasn't the dullest patient in the unit anymore. They saw her as a human. All the students were going in and saying, tell me about what that was like. Really, help me understand. And all of a sudden, she became a real person, and people started looking at her in whole. And they came together and they said, we will never let this woman languish in a bed. We will never call her dullest again. We will help her to restore her sense of self. We'll find her a home. And it's that idea of saying what matters to you, who are you as a whole, that's changing everything. In Norway, there's another nurse who was in Paris decided that he would go back to his nursing home, and he would start to not only ask the patient, what's your diagnosis or what matters to you, but how can I help you best? And what he did was he said on June 4th in 2014, I'm going to make What Matters to You Day across the whole country. He started this, and eventually the next year changed to June 6th. But what he said was, let's go in and change people from being clinical conditions to being people. And there's a great whiteboard in the nursing home that I visited where it used to be the patient's name, their age, their doctor, their DNR status, and then all the other stuff. And he changed the whiteboard. So now it's the patient's picture, what they want to be called, what matters to them, and all the other stuff. And so I was there in front of the Norwegian board and said, what does this guy want? Oh, he's an 83-year-old man. He wants 2 scotches every night at 5 o'clock. And then this woman, what does she want? It says in capital letters, never take me out of my room without my hair done and without my makeup on. And you stand there and you're just filled with joy because you know these people, and it's totally changing the conversation. So Anders Vega, the nurse in Norway, decided that he would spread it from his nursing home to the entire country of Norway. And it's gone now to Brazil, to Scotland, to Italy, to British Columbia, Canada, to Denmark. And last year, on June 6th, 2018, 31 countries had all of their healthcare organizations working on What Matters to You Day. All the staff on the units did celebrations, what matters to the patient, what matters to the family, and what matters to each other as staff. So I would ask you, June 6th, 2019, to put that on your calendar. It's creating incredible changes in the culture of healthcare, and it's creating joy in work. 20 million tweets last year on that one day, all about what matters to people. One of the staff I was working with in the United States said, you know what, you have ventilator bundles and central line bundles, why don't we have a kindness bundle? So she created a kindness bundle, and it helps people when they're going into a patient room or into a visit to actually stop and think, how can I make this communication about a person and not about a clinical condition? And what we're finding now is that basic acts of kindness are leading to faster wound healing. Who would have thought that? What we're finding, I just read a book to write a review of it, and it's called Compassionomics. It's coming out in April, and I would strongly encourage you to read it. What we're finding, and this is done by physicians studying academic medical centers across the United States and abroad, what they're finding is when you stop to be kind to someone, you are actually changing the clinical outcomes. You're reducing pain. We found that an anesthesiologist who stops before an operating procedure, touches the patient's arm and just says, I'm Dr. So-and-so, I'm going to be taking care of you, it'll be great, and I'll see you when you wake up. That small act is decreasing the amount of anesthesia that the patient needs for the procedure. When somebody just walks in and the patient doesn't have any connection to the anesthesiologist, the pain goes up. So you can see that basic acts of kindness are totally changing the way that we think. And I'd encourage you to go back and think, every single day, how can you as one nurse do one PDSA cycle and find your own joy by reaching out to patients? It's making a huge difference, I think, in clinical interactions, in social interactions around the world. And a quick example is a patient that I met in the United States, Gilbert Salinas, who became paralyzed by a gunshot wound. And I asked him about his care, and he can tell you in great detail how his clinical care was excellent. He can tell you about his medical record and the care he received. But one day I said to him, what was the most meaningful moment that you ever had during your hospitalization when you found out you were going to be paralyzed? He told me that he was 19 years old. He said that a physician walked into his room about 6 o'clock one night, and he still had hope that somehow he could be fixed. And he said the physician walked into his room and said, Gilbert, you're paralyzed for the rest of your life. You're going to be in a wheelchair. You're never going to walk. You're going to have all kinds of problems with your skin. Start thinking now about who's going to take care of you for the rest of your life. And Gilbert told me, and this was, I'd known him for some years, he said he just lost it. And he started crying. And he said his nurse who came in, she was there, it was 6 o'clock. She was supposed to go home at 7 o'clock. He said she walked into the room and she saw how distraught he was. She saw that his life was changed in that moment forever. She got on the bed with him, sat on the bed, and she put her 2 arms on his shoulders, and she put her head on his chest, and she stayed there until he stopped crying. It was almost 3 hours. And he said he will never forget her, because as much as the clinical care meant something to him, she saved his life. And what we're finding is that nurses, when they step out of clinical roles and they do basic acts of kindness, that the impact is way beyond anything that we learned in nursing school. I was in a hospital in the United States, and I met and I said, bring me to the place you're proudest of. And they brought me to a small group of nurses. It was like one table, sitting around in the basement of the hospital, no windows. And there was so much joy in this group. I thought, how can you get joy if you're not out doing things? And I said, introduce me to somebody that you met, that you know about, that you care about. And one of the nurses said, well, I've been taking care of this lady named Ethel. She's 93. She's been very independent her whole life. And last summer, her husband died. He was her only person in her life. They had been married for 60 years. And Ethel became very lonely. And so the nurse said that she kept coming back to the emergency room and being admitted. And then at home care, she said that she started to send in a nursing assistant first every week and then every day. The nursing assistant would bathe her, feed her, put her in a wheelchair and sit her in front of the television. And one day the nurse said, I said to her, Ethel, what matters to you? What would make your day good? And she said, I want a dog. And so the nurse said, Ethel, I'm the nurse. And Ethel said, I want a dog. And this went on for a few weeks where the nurse kept trying to say, I'm the healthcare person. I want a dog. So one day on the way to visit Ethel, the nurse stopped at the dog pound and she brought Ethel a dog. Within 2 weeks, she was walking 100 steps by herself. And now, 2 days a week, Ethel goes to the hospital and she plays the violin in the lobby. So Ethel has gone from being completely dependent to taking care of other people. So here's Ethel with her violin and her dog. And it's all about a tiny act of kindness that saved this woman's life and is changing everything. So I will leave you with a couple thoughts. One is we need innovation. Nurses sometimes, in my experience, innovate under the radar. I was just walking through a hospital in another country recently, and there were a group of clinicians from other disciplines, and they were saying, look at this, look at this, look at this. And when I went to the nurses, they said, look at this, don't tell anybody. I think we need to raise up the innovation capability of our profession and see what meaning it makes. I think we need to spread. That's what I love about this meeting is I'm challenging you to learn something and to take something home, to teach something. At IHI, we say, all teach, all learn. That's the mantra, and I think it's so critical. And then I would ask you to exnovate, because nurses are notoriously not good at exnovation. I can see that not everybody in the room knows what that word means, but it means getting rid of all the junk in our lives. We add procedures and guidelines and equipment and medications, and we never take anything away. You open up a closet on a nursing unit, and you'll find everything from when I was a nurse. So we need to get really good at exnovation, because the more we can streamline and clean the things that don't matter, the more energy and time we'll have to be kind to patients. You may have seen this from the Netherlands. A group of nurses were looking at a pediatric hospital at how scary it was for a kid to go to the operating room. And so what they did was they went out and they got the automobile manufacturers to donate cars, like there's Mercedes and all these, and the kids drive themselves to the operating room. And what they're finding is it's totally changing the balance of power. These kids aren't scared. They're driving the car and their parents are chasing along the hallway, but they come into the operation with a sense of control and empowerment, and it's totally changing the way that they look at healthcare. So I would say learn exnovation, learn undiffusion. Anytime you go to diffuse a new guideline, you've got to undifuse the old one. These skills we didn't learn in the old days, but they're a dramatic improvement over just adding and adding. And the more that nurses get skilled at exnovation and undiffusion, the better we're going to be at allowing ourselves to provide kindness. Focus on your IQ. You're learning here today. You've learned so much from the science of medicine. Focus on your EQ, your empathy. And sometimes when we get busy, that goes away. But I would say most of all today, focus on your CQ, your curiosity quotient. So you've all heard about the Nursing Now campaign, and there have been lots of examples around the world. I have the good opportunity to work with nurses like Charlotte and others around the world to try and say, we need to lift up our profession. We need to get more nurses in board roles and leadership roles. We need to decrease the angst of nursing and inspire joy. And I'll end up with just a very 2-minute video that will, I'm getting the 1-minute sign, so.